So it is 2 o'clock, so we will go ahead and get started. Thank you all for joining. Please note that this session is being recorded and will be posted on our YouTube channel as well as emailed out following this session. So if you would like to please stay on mute during the session, we'll have time for questions and answers afterwards. I'll first introduce Elizabeth, who will then introduce our presenters for today. Elizabeth Burrows is an alumnus of North Vermilion High School and graduated magna cum laude from DePaul University with a degree in political science and communications, where she studied abroad at Oxford University. She then went on to receive her Doctor of Jurisprudence from Indiana University Maurer School of Law. Elizabeth has worked at the Indiana State Department of Health as the Director of the State Office of Rural Health, where she more than tripled the amount of federal funding for critical access hospitals. Elizabeth then returned to Cayuga, her hometown, to start up and serve as the founding CEO of Valley Professionals Community Health Center, which grew over 1,000% in the 8 years she was CEO. In 2014, Elizabeth started her own business, Burrows Consulting, where she has assisted numerous rural health clinics, federally qualified health centers, institutions of higher education, critical access hospitals, and other nonprofits attain over $150 million in grant funding, and also enhanced Medicare and Medicaid reimbursement and 340B shared savings. So Elizabeth, would you go ahead and introduce today's presenters?
Hello, thank you everyone for joining. Sorry, I don't have our presenters' big bios today, but I will tell you a little bit about both of them. And actually, it's something that we get asked all the time, which is, one, how do I make the most money off 340B? And two, how do I get my own in-house pharmacy, and how can I do this and get around all the new rules and regulations? And I went down the Google rabbit hole and I don't know what to do. So this is actually the webinar that we're having in response to that. So actually, in response to what you guys have been asking for, we decided to host this webinar. I will say that Burrows Consulting and Nuvem, or 340 Basics, work together quite a lot. We do work with a variety of other organizations too, and I know many of you have different third-party administrators, but again, this is going to be a solution for you that does not require adding additional staff right now, which has been what you've wanted. So I'm really excited to introduce Chris and Jackie, who both work for Nuvem. Chris Espelin is the vice president, and Jackie is the director of the pharmacy program that she does, the in-house pharmacies. Some of you may have known them under 340 Basics and under Apovia. Now they're Nuvem, and I'm really excited because we have had success with our clients working with both of these people, working with pharmacies, whether that's through contract pharmacy or in-house pharmacy. If you are on the line and don't know what to do, I will tell you. And right now I am an interim, actually FQHC CEO. I would be starting my own in-house pharmacy right away if I ran a health center. So I just want you guys, hopefully you could learn from this short presentation. Please put your questions in the chat, or you can email Hannah or me directly, and we will be glad to ask those at the end of the presentation. Without further ado, I will turn it over to Jackie and Chris. Thank you for joining us today.
Thanks, Elizabeth. Let me share my screen here. All right, can you see my screen?
We can see your screen, but it's not in presentation mode.
It is now.
Perfect.
All right. First off, thank you, Elizabeth. Thank you, Burrows Consulting, the entire team. We're honored to be part of this and share our experiences. Elizabeth and the Burrows team, we've had a great partnership the last few years. We've brought a ton of value to our client base, and we're really excited to share with you today. So without further ado here, let me move my video here. We've got a few things today. So the agenda is less salesy, even though I'm the sales guy. Today, we're really going to open it up about who is Nuvem. I know there was a couple of brand names thrown out there. We've done a lot recently, and so I think it's important to start with that. We're going to then talk about why an in-house. I'm going to pass it over to Jackie then, who's going to handle questions consider, what success looks like in in-house pharmacy space. There's a small slide that then I will take that's my favorite, and then I'll pass it back to Jackie to talk about the financial feasibility, the risk, and the key areas around pharmacy. And then we'll kick it back a little bit to talk about process of opening, some of the options out there. We'll walk you through a little bit of the implementation and other types of questions to be thinking about. And then I'll close it up with why Nuvem and next steps. To go off what Elizabeth said, if you have any questions, put them in the chat. At the very end, if you have any questions that I can't answer, or Jackie, we have a big, beautiful team behind us. Within 24 or 48 hours, we'll get with, members of the team, compliance, pharmacy, et cetera. And we'll get those answers back either individually or put it in the group or send them to Burrows to send out. So I think it's important here just to spend 2 minutes and talk to you about who is Nuvem. So one, you understand who is speaking up here today, and also to bring credibility that, the sample size and the education that we're bringing today and some of the pointers and experiences are real life, and we have a big client base to pull off of. So we've been around for roughly 9 years. Many of you probably know Colleen DeClaudio, 5'2", bleach blonde hair, not only the smartest person here at Nuvem, but one of them in the industry. She was the CFO of a large health center in the Northeast, decided back in 2014, there's got to be a better way than working with my current partners. So she created her own technology. She then branded it in 2015. Many of you on the conference today probably know us as 340 Basics, or did, as we were a very large TPA, third-party administrator, and that's really where our brand started. From there, over the course of the years, we added solutions, we enhanced solutions, we added a compliance and auditing arm in 2017. We split into contract pharmacy, Portico, and added the addition of our splitter or mixed use in the hospital space called Invictus. In 2019, we added the service piece of referrals. So we go out there and outsource this service piece to a lot of our clients. In 2020, we partnered with Microsoft to form Business Intelligence. That was right about the time, if you remember, the pandemic. Also, manufacturer restrictions, there'll be a lot of conversation around today. 2021, we formed Securic, which is our pharmacy gateway. And then even though we've done a lot with pharmacy management, consulting, and all those things, we decided to purchase or acquire a pharmacy called Apovia a little over a year and a half ago. And so just a few weeks ago, and why there's a lot out there, if you're thinking, hey, I see all of this up here, it's a little confusing on the brands. Now you understand why we rebranded for Coalition. So just a few weeks ago, we rebranded to Nuvem. So today we're an integrated pharmacy partner. We can run all aspects of the 340B program, even if we're not processing the specific claims and you have a great TPA or whomever. We'll talk about it a little bit more later. But to bring some credibility to what we're talking about today, we have over 330 covered entities today that use our platform. Most of them use us in a bundled package, meaning most of these are full suite clients. Some of them use us for just certain suites, but we have 330, and so we have a big sample size to give you education and data today. So why an in-house pharmacy? I think it's a lot of questions today, and probably where most of the in-house pharmacy questions reside is, hey, why didn't I do an in-house pharmacy previously? What does an in-house pharmacy mean to me today? And I think a lot of it is being stemmed around manufacturer restrictions. And all of you on the phone are aware of those, and we're going to go through those in a little bit. The other reason why I have an in-house pharmacy, it's all about the patient outcomes. So because of manufacturer restrictions and other variables to it, drugs are no longer affordable, or patients don't have access to them. At contract pharmacy today, an in-house pharmacy provides that protection, also removes any of the barriers to affordability. There's also chain pharmacy limitations and state Medicaid changes. So depending on the state that you're in, you may or may not have been able to carve in MMCOs, managed Medicaid. Some states have just recently changed. If you're in New York or Pennsylvania or California 2 years ago, right? That change from being able to have the financial savings on MMCO to not has probably impacted you financially. There's also been a decrease in pharmacy service availability. So due mostly to staffing. We all went through a pandemic. We know how that has changed the landscape around staffing and employee-employer relationships. More employees want to be remote, which has put more pressure on companies come up with ways to offer employees benefits to come in, as well as most individuals now are more in a relationship of getting on my phone or have it delivered, and all those and yet you still have to hold a brick and mortar store. And then many of you are probably having this challenge today. There's a challenge of clinical integration across multiple pharmacies. So if you have any clinical programs or services with patients today that you offer, you're working a multitude of pharmacies, whether or not it just be a select few in the big chains or a local independent, but your patients are probably going to a few dozen, if not a few hundred pharmacies. And so the challenge of having an integrated clinical program or service is very, very difficult across a multitude of pharmacies, and a pharmacy that you don't have any control in, and struggle to communicate. These are the main drivers for an in-house pharmacy today. Why it's the number one question today, why there's a sense of urgency around it. There's a big green box on this slide. If you read it, it says fear of the unknown has been replaced by fear of losing needed savings and patient access to much needed discounted medications. I'm not going to go through it, but on the right-hand side of the slide, there's a list of 22 manufacturers. If you look at it, many of these manufacturers came across the timeline of the last 2.5 years, and many of them came out just with restrictions on hospitals, and then recently gotten tighter and tighter on FQHCs, and it's really caused financial concerns across the covered entity landscape. It's the biggest driver when discussing an in-house pharmacy and the urgency around it. Wherever you're at in your continuum when it comes to manufacturer restrictions, the concerns around data submission, not just what they'll do with our data, but more importantly nowadays, right, the resources it takes to gather this data and submit it, and how often, it's quite a process. And so regardless of where you're at with it, I would say today, and where your concerns are with an in-house, may change tomorrow. The slide might be updated by the end of the day or next week or next month, as manufacturers seem to be coming out periodically with tighter and tighter restrictions. And so that goes to why an in-house, why now, and the urgency. And I'm going to kick it over to my partner, Jackie, here to discuss the benefits of an in-house, considerations, and then success factors of an in-house. Jackie?
Yep. Thanks, Chris. So now that you better understand the urgency around manufacturer restrictions, let's visit some other benefits of in-house pharmacy. Ultimately, there's two main drivers of in-house that are improving patient and financial outcomes. Patient outcomes, excuse me, would include improving access to medications by facilitating more access points to medication, especially for those patients that you may be serving that have transportation or communication barriers. We know that many patients that you're providing services to can struggle to get a ride to a pharmacy, to just pick up a prescription after an appointment at your clinic. So what we want to do is make sure that we have an area where the patients feel comfortable filling a medication because of lack of insurance, maybe lack of the ability to pay. Maybe they speak another language, or because maybe they don't want anybody to know that they are getting treated for a condition that they consider to be very private. In-house pharmacy can really reduce individuals, hesitation to use pharmacy. In-house pharmacy can also reduce out-of-pocket costs for patients and eliminate all of the extra fees that are associated. So with manufacturer restrictions, in the contract pharmacy space, when you shift that to an in-house space, you're having more access to medications that they're able to have because they're available at the 340B prices. Prior authorizations and rejections are also a huge component of patient outcomes inside of a pharmacy. Processing those quickly and have the pharmacy sort of quarterback those interactions are really important. In the traditional pharmacy space, out in the community pharmacy world, patients appear at a counter, they hand over a prescription, they realize it's not covered, and then the pharmacist maybe takes a day to call back the clinic. It sits at the clinic for a couple of days, they call the insurance calls the clinic back. And in the meantime, the patient is stuck in the middle, going back and forth, trying to figure out, how to manage that or how to get it quickly. On average, it takes a clinic around 16 days to process. It takes a pharmacy 6 days to process. And it takes a pharmacy that Nuvem controls 2 days to process. And those are APHA from 2021 numbers. There's also ways to improve clinical integration. So the ways that your pharmacy is talking to your clinical staff and making sure that your individuals that you're caring for are getting what they need. And that medical home model where they're becoming a part of the care team and becoming a hub for the services. Now that includes pharmacy. The other way to improve outcomes is obviously the financial outcomes. We understand that finances and the 340B program is meant to add dollars to your organization. So manufacturer restrictions, as Chris just spoke about, the list is long, it represents a lot of dollars, and it continues to get larger. Being able to optimize monetize those claims in the in-house model is very important. Better margins, so less fees around all of the fees that you have in contract pharmacy. So your gateway fees, your TPA fees, any processing fees that are associated, those will go away in the in-house pharmacy model. So you're able to make more money on each claim. Referrals and other high cost drugs. So you're able to have more visibility into the referral program, what's being written, where is it going, who's capturing, is it a 340B drug that's restricted in other places? How do we find that and bring it where we can capture it at the highest availability? And then also your ability to manage a more successful sliding fee scale. So more often than not, there's lots of different levels, poverty levels that patients may fall into. And being able to not only assess real-time financial data that you have in your EHR system that contract pharmacies may not be able to, you would also maybe have a few different sliding fee scales for maybe somebody that's Medicaid pending and somebody that's completely uninsured. So being able to have more control over that and ultimately save dollars while getting people their much needed medications is super important. And we want to stress here that an in-house pharmacy will complement a contract pharmacy network. It does never really replace that pharmacy network. You can click the next slide. So before jumping into a pharmacy business and taking a nosedive into, something foreign and unknown, there's a lot of things you might want to consider. It's very different than running an FQ or a lookalike or a Ryan White program. But you first want to make sure that pharmacy business can be supported. The last thing you want to do is open up a pharmacy and have it tank because you weren't adequately prepared for what the finances look on the payer end, which is going to be much different than what it looks like on the medical end for you. So the first thing you want to look at here is, the volume of patients. Do you have enough to support a pharmacy? And in the mix of medications, plays into that. What's the insurance mix? Some payers are better than others, and we need to understand what that looks like across the board and what mix of, how many patients does that represent? What kind of medications are they on? Do you have the right space for a pharmacy site? Where the space is located can be an absolute make or break decision on your part. And I would caution anybody that's, really considering seriously about a pharmacy that has space in the back of their clinic, way in the back corner, to take the time, effort, and even cost to shift around maybe some places in, spaces in your building so that optimal pharmacy space becomes really a part of the workflow of your clinic. How do patients walk in? Where do they go to the reception desk? They go, how do they filter through the back of their clinic when they're being seen? And then where do they exit and where would that meet picking up the prescription? And having that tie in and making sure that it is not only visible, but accessible for folks that are coming in for refills that don't necessarily have an appointment is again going to be important for that ongoing success. Understanding the length of time involved from construction to filling the first prescription to becoming profitable. Those are really 3 distinct time frames on your timeline. You're going to need capital to be able to support some of the costs associated and some of the operational costs associated once that pharmacy is open. The day you open your doors does not mean you're making money. It means that you're filling prescriptions and that you're busy. So knowing that opening your doors, there's going to be cost involved with minimal benefit for the short term. The goal is to make sure that you have a plan to make that a really good financial venture for you. And lastly, before you jump in, do you have the people on staff, or do you have the people that you are contracted with or consulting with that have the expertise needed to open a pharmacy? There's very specific ways that you go about opening a pharmacy. There's very specific things that you need to be compliant of and understand to manage a pharmacy effectively. And then really understanding how to integrate that in-house pharmacy into the bigger 340B program that your organization offers, and where the holes are and how to fill in those gaps is so important to the ongoing success of this or the pharmacy operation. So making sure that you have all of those things thought through really in depth before. And if you're thinking that some of these, items, maybe they're a little bit out of your wheelhouse of expertise and knowledge, that's really that's the time to engage with somebody else that may be able to bring something to the table for you. Go ahead, Chris. So a successful in-house pharmacy, what does that look like? There's three kind of really big main functions that a pharmacy is going to be doing. First, the most basic functions of an in-house pharmacy are your filling and billing functions, right? That's the thing that's going to keep your pharmacist and your staff engaged and busy every minute of every day. You're answering phones, maybe people have questions, maybe it's the clinic staff consulting with you on, a change in medication. The pharmacy staff is going to be busy. So really making sure that you don't have a siloed approach to managing that in-house pharmacy, and making sure that you look at it from a very comprehensive model to optimize the financial and clinical outcomes of your clinic and your patients is really the most important, place that you can decide to engage. That pharmacy will operate. You will bill prescriptions. You will make some money. How does that make sense into the bigger picture for you? So how do we do this? So looking at the clinical programs, we want to make sure that we're, creating some meaningful programs that speak to your clinicians and the way that your organization gets paid. So are there, adherence outcomes, adherence metrics, pay for performance programs, disease state management programs. You want to make sure that you're aware of what they are and understand how that pharmacy can really lean into the profitability of, not only that pharmacy, but then also, maybe increase payments to your clinic. Patient access, again, I spoke before about the prior authorizations and rejection management. How fast can you turn over a prescription that is being rejected at the pharmacy level? Not only will that have, negative financial effects for you, but it has, many negative effects for the patient not accessing medication care when needed. Then you can go into your referral and high cost prescription targeting. So really understanding how referrals work, if you want to participate in a referral program, and how you can look at that once you have a pharmacy operation. Then once you have, your filling services, you have your clinical services, and then you look at your integrated program. How does that all come together? How do we know what we're filling, for who we're filling for, what medications are still out there, what's being restricted at a contract pharmacy? Having a really good data solution on the back end of that will really help you identify not just what's here in your in-house pharmacy, but what exists in your entire contract pharmacy network. How do we improve that? How do we continuously, make that better? And especially as more manufacturer restrictions potentially could be layered onto this, it may get harder and worse in the days and months to come. Visibility into referrals, do you know what you're filling? If you have integrated clinical services, you're likely doing medication reviews and med recs with all of your patients. You're asking them and checking with them on what other medications they're on. Then you understand better about what your referral program could look like, or how to go and obtain those prescriptions, transfer them into the pharmacy to begin capturing them at the in-house. And really that's in best clinical care for the patient anyway. Understanding what you can capture at an in-house versus externally in a contract pharmacy. There are some states where managed Medicaid plans can be captured in one and not the other, non-exclusive providers. So really the goal is to understand the program, have data in the background that supports that, but not make it limited to just the pharmacy or just one contract pharmacy TPA vendor. How do you pull in all of those different components? Because, CVS has their own and Walgreens has their own, and you may work with 2 independent TPAs. So you have all of this data everywhere. Making sense of it is really, really important. Chris is going to take the next slide. It's his favorite, that really talks about the actionable data that our vendor aggregator can provide.
Sure. So thanks, Jackie. Jackie's done a good job about talking about, we talked about why the pharmacy, the benefits of an in-house, and then the success of an in-house. And a lot of that comes on your integrated program, right? As Jackie used the words, right? Filling and billing. You're going to open a pharmacy, you're going to be very busy filling and billing, answering questions. But there's so much more that goes into your script universe and everything that you probably have today. And so this slide is, while it's my favorite, it's very, very messy. And so today you probably have multiple contract pharmacies. You have prior auth and rejections you're doing today. You have Walgreens over here. You have CVS and Well Partner, maybe another TPA. You have the program management at all of it. You have clinical programs. Maybe you have a couple independents. You've got different referral programs out there. And then you have everything into audit and compliance. And so this slide really talks about you as a covered entity, even if you have the best TPA, the best multiple referral providers, the best data analytics, the independence, all the components, it's still a very siloed system. And in order to be efficient and optimized for the best outcomes, you as a covered entity have to gather all the data from all the parties. You have to combine the data, turn it into something useful, be able to make decisions, and then go out and execute it with your different vendors, with your in-house pharmacy, who's going to do it. And then by the time you get all of this done, just like the 340B program and what we talked about manufacturer exclusions, it's all outdated and you got to do it again. And so with Nuvem, where I wanted to go with this and just clarify, even though you know us as 340 Basics, or we've done things great with as a TPA, if you have a great partner today or a great vendor, keep them, right? Nuvem can put a circle around this. We have data connections with all of the big players out there, from pharmacies to other vendors. We have a vendor aggregator where it's one portal to come in so that you have a holistic approach, so we can look at a program and make better decisions, both for the in-house as well as your entire program. And so that's what we offer today. And that's what a covered entity should be striving for: integration of your entire program. Probably the most important and best slide, though, for the covered entities, for all of the audience out there, is let's talk about the financials. Jackie?
So thanks, Chris. So important to really understand the financial risk and sustainability of a pharmacy operation. When we're engaging with a customer, we really try to walk them through a very detailed understanding and pro forma of how we think and really believe that their pharmacy will perform based on some information that we ask them for, eScribe data, and a lot of times we have financial data on the back end through our TPA program, so that we can really make this pro forma be as accurate as possible. So looking at this example that we provided in here, the chart, this is an actual clinic in a rural community. We know first, so if you look at that second line there, the cash reimbursements, it's going to be the same the entire way across, because we know from the day we open the doors of that pharmacy, we're going to get probably every uninsured patient utilizing that pharmacy because the costs are going to be lower for them and for anything the clinic is going to subsidize, because there's so many less fees associated with dispensing a prescription. And not only that, they don't have the barriers around transportation and coordination of getting prescriptions out to them afterwards. But when you look at this, starting on the far right-hand side, if you look at the 5% capture rate, the net savings to a CE is just under $200,000. And as you move back, I'm sorry, it's starting at the far right. As you move left on the yellow column, capture at 10%, under $1 million. Capture at 25% is 2.3 million. Moving left along this column and looking at the different capture rates of patients that have payers on their prescriptions, that is where the success is going to be on an in-house pharmacy. And capturing all of those uninsured claims may lead to a small amount of profitability with minimal capture of different payer claims. But really the goal here is how can we drive the success of that program to capture a higher amount of the individuals that do have payers that will drive the success of the in-house pharmacy program forward. So, what are the risks around this? We know what the pharmacy can do, but then how can this fail? How can this break? How can this not add up like we think it will? The first way is not understanding what your startup costs are going to be. Not only, build out inventory, processing costs for some different applications and payer networks, but then making sure that the further you get into filling prescriptions after you open, and the longer you're paying staffing and not monetizing payer claims, the more money that you're going to have to dump into that. So the time it takes for you to get ramped up and to capture a higher percentage of your patients with payers really, is a risk factor, because if you don't plan that the right way and have a plan on how to do that the right way, it's going to lead to a lot more costs than you anticipated. Next is not having the right pharmacy staff. And I'm going to interject a personal part of the presentation, but aside from my role at Nuvem, we have a family business in the community pharmacy space. And my husband is a pharmacist and currently works as a pharmacist at our pharmacies part-time and runs the business full-time plus. I can speak from experience, in our time, working together for, almost a dozen years, that having the right staff and the right pharmacist running an operation is so very important to a successful pharmacy operation. He's there every day, and still he can't be in all of the sites every day. So even when you do have somebody that is knowledgeable and understands, they're not there and overseeing every task, every order, every bit of everything that's happening there. It can have a detrimental effect on cash flow in that space. Inventory running lean, planning for, coverage and vacations, planned and unplanned, growth plan and staff. Do we have an in-house problem solver for when things break unexpectedly, or when the power blinks in the middle of the night and your alarm system is going off? What do you do? Who is going to be the one that addresses all of those things? So having the right staff that has the right mindset, that is not only there to be probably a really great clinical pharmacist, because almost all of them are, but also have that business mindset to really make that a successful venture, is going to be imperative to the successfulness of that pharmacy. Next, like Chris talked about, is the data visible in a way that makes any sense for you to be able to be able to act on it? Do we know what prescriptions to target? Do we know where our patients are going that isn't leading to a lot of success for our 340B program? How do we target those? What's your plan? And then who is going to do all of these things? It's not going to be your pharmacy staff. They're busy. They're filling and billing prescriptions. Who is going to do all of these things that are going to not only engage your patients and your providers and your support staff and the front desk staff and all of the other people that are involved in this process? You have to recognize that that's sort of a separate role that is very tied into all of this. And then at Nuvem, like Chris said, not only do we provide the in-depth for a possible in-house pharmacy, but our goal is really to minimize the financial risks associated with all of the operational hiccups that could occur in this process. So the key areas to consider, Chris, next slide. So as you can see, whoops, Chris, can you click the next slide?
Sorry,
There you go. So, there's a lot of decisions that need to be made during this process. And looking at this and all of these elements are just, a brush stroke on the things that you need to understand and do every day before, during, and after opening of a pharmacy. So all of the, build out and licensing processes, applications to the board, all of your credentials and provider IDs, picking a pharmacy data management system. What are they going to use to process all of these claims? What's the connectivity going to look like? Who's going to make those decisions? Pharmacy operations, hiring and training the staff. How do you do, does anybody know 340B that you're even hiring, and how do you teach them that? Connecting with a wholesaler, building out, some type of per diem staff network, reverse distribution agreements. Do you have delivery? Those are all of the operational aspects. Patient and provider engagement. How are we connecting our patients to this pharmacy? What are we doing inside of the clinic that educates our patients in a way so that not only do they know that this pharmacy is there for them to use, but understand the benefits of using it? Clinical administration of programs. So, claims reconciliation, EMR assisted safety optimization of the medications, because you would have dual access, prior auth completion, rejection management, all of the items that allow for administrative burdens to not bog down the pharmacy operations. 340B program optimization. So again, integrating that 340B program into the whole picture here, not just a siloed pharmacy, but what can it do for us? How does it work hardest for us? And then making sure that we're targeting the 340B leakage. So looking at not only the in-house pharmacy, but all of the contract pharmacies that we have engaged with in your network, and what's happening outside of that network, and how do we make sure we target those and pull them to the in-house or somewhere in the network. Pharmacy compliance. So, just like your clinic, there's a whole set of rules for pharmacy that you have to follow to be able to be compliant in the pharmacy space. Then Medicaid layers on special rules, and Medicare layers on special rules, and PBMs all have their own rules. So making sure that you're not only compliant on the state and federal level, but then all of the individual program and payer levels as well. Also audits. So you would be subject to, participation in the HRSA audits. And then you're going to layer on PBM audits, which is the pharmacy benefit manager audits, where they will periodically, and I promise you probably at least quarterly, ask you about your high dollar claims and, what you dispensed and how it was written, and want copies of those prescriptions that you have to send in. And it's a big task and can be a pain to facilitate during normal operations. And then tech solutions. I'm no tech wizard, and I think that most people in the pharmacy space are not. Things will break, and who are they going to call to fix their pharmacy system, or if a payer network is down, or when the lights blink in the middle of the night, who's going to troubleshoot and manage that, or be able to answer billing questions to make sure you have that bench and make sure it's deep, because you will run into some issues inevitably. All right, Chris, we'll talk about operations and cost.
Yeah, so if you've listened to the past few slides of Jackie, there is a lot to consider when evaluating a pharmacy. You have a few options. The three options here, outside of many others here, would be to own and manage the pharmacy yourself. And then you're going to have to go through the pro forma, the financial risk, and then everything to do with the key areas that Jackie just stated, to look at everything from operational to strategy to how are we going to do this, the setup. Everything would be owned and operated by the covered entity. Option number two, get a consultant. The consultant out there can help you open a pharmacy, provide some feedback to optimization, can get the ball rolling as far as open your own pharmacy. And then the third option, where we're seeing more covered entities move to, and actually more covered entities even that have one of the first two options, move to an outsourced management model. And the reason why is all the complexity that Jackie just spoke of. The covered entity is going to own the license, but they're going to outsource the management of the pharmacy. And in our particular instance, the entire 340B universe. So we're going to be able to pull together all the components of the program and make sure we optimize that pharmacy. So own and operate, own and outsource, or use a consultant. Those are probably the three most prevalent options today. And then also the cost of doing so. Most of the costs associated with all three options are relatively the same. There's a few exceptions if you use us at Nuvem, some of the things that we cover and all those. I think the biggest thing here is just to outline some of the capital costs that you're going to have when opening the pharmacy, from design and construction and build out. Got to think about where you want to put it, the construction cost to it, where you need shelvings, refrigerators, the sink and water access, pharmacy IT software and hardware, who you're going to use, what's the cost, or outsource that. Some of the security stuff, you're obviously going to have to work through the process, potentially even hire a pharmacist up front to go out there and get a pharmacy license, to do your credentialing, your payer contracts. You're then going to have the initial drug inventory. And of course, you have staff prior to opening. And so all of these capital costs, even though we didn't put a range here, we can put some ballpark figures to them through a conversation with us or individual you go to. You'll see at the very end, if anyone wants to go down this road, this is part of the evaluation process, and we can help you give a range to all of these. So a couple more slides till we get to the end. Jackie, I want to leave time for questions here. So Jackie's going to take you through really quick a high level of implementation so you all understand what it looks like to open a pharmacy, and then a few other decisions just high level that that you'll have to make through the implementation process.
Sure. All right. So implementations, super high level here, and to not, waste too much time. You can estimate approximately 6 months to implementing a pharmacy. There's a couple main areas that really get hung up here, and that can be, the first would be, the construction. How elaborate is this construction project? Are you adding a wing to your building, or are you modifying, an office space that's adjacent to your lobby area? But making sure that you have engaged with the contractor, they understand that your timeline is short, and making sure that you're doing all of the necessary, items to push along the construction process quickly is ideal. Secondly, some states are inevitably quicker than others at processing pharmacy licenses. So after build out, you'll be making an application to the Board of Pharmacy of your state, and some will process really quick, like within 30 days, and send an inspector out. Others may take months to do this. So understanding the state dynamics and how long it may take your state to process and approve that pharmacy to give them a license to move on in your process. And the third place is sometimes Medicaid can take a longer time to get your Medicaid provider ID. A lot of times that provider ID is required to complete applications for the different Medicare and PBM networks. And if you make a mistake on that Medicaid or Medicare application, they will send it back to you. And then once you make the correction and send it back to the agency, you get in the back of the line again. And it may take 60 days for them to review again. So making sure that, you're moving through the parts of the process that you can control quickly, so that these parts of the process you can't control, you're doing your best to, mitigate the time it takes. I think that's a pretty, that's some can take shorter, some can take longer. It just really depends on the state that you're working with, and if there's any barriers in unforeseen barriers in the build out process. You could go to the next slide, Chris. And again, once again, so many options and decisions that you have to make before, during, and ongoing in this process of a pharmacy. Where it is, how you're going to facilitate that space, whether you, start a pharmacy de novo or you purchase something existing and take it over. How will you facilitate, folks being able to pick up prescriptions? Drive-through, delivery, walk-in, is it accessible? Do you have a good pharmacy data management system that you can use to fill and bill prescriptions? Wholesaler, secondary wholesaler. Who should you contract with to be able to do different pieces of this? Who's going to write the operational policies and procedures for the pharmacy that are specific to pharmacy law? Preparation for different audits, HRSA and PBM audits, engaging with your staff to increase utilization, managing 340B and non-340B inventory, physical separation or virtual separation. What are the benefits and drawbacks of each? And then payer reconciliation, because when you do bill claims, you want to make sure you're paid, because, it is sometimes PBMs, sometimes the checks go to other places by accident. Not everybody pays through EFT, believe it or not, in 2023. Sometimes you get a cold hard check cut and you want to make sure that you're getting those too. So making sure that you have some kind of payer reconciliation, either person or service that is looking out for those payments coming in. But there's lots of decisions to make here. And, lots of these will affect the operations of your pharmacy. Each of these decisions seems very small, but when you put them all together, they can have a pretty large impact. Chris is going to wrap it up and talk about Nuvem and who can be your integrated pharmacy partner.
Thanks, Jackie. Look, I think if hopefully everyone here on the phone or webinar took something away today as far as why an in-house, the benefits of an in-house, manufacturer restrictions, the importance of everything that goes into the pharmacy operations and how it's so different than what you all do on the medical side of the equation. And then more importantly, I would say is the success of the pharmacy is so much more than, as Jackie said, filling and billing. You're going to be busy. You're going to be busy filling, billing, answering questions. Uninsured patients are going to come in. Your Medicaid patients are going to come in. You're going to get some payers in the equation. But how do you optimize the pharmacy? How do you have better financial outcomes so you can impact more patient outcomes? And it's truly having a partner out there today, a partner that can integrate your entire pharmacy program. Whether or not that partner is actually the one that's processing claims or executing is one story. But a partner that can pull together all the best components of your program, put them under one holistic view. That's what Nuvem can do. So you can make better decisions, or we can make better decisions for the in-house, for your contract pharmacy, for your patient, and ultimately a covered entity. So what are next steps? Before we go to Q&A real quick, there's really 3 next steps that I would say for all of you. First one is business decision, right? You have to have a strategic planning session. Does an in-house pharmacy align with your business objectives, strategies, and missions? That's something you'll have to have a discussion as a leadership team, board of directors, and all that. Number 2 would be to reach out to either Nuvem or someone out there to help you put together the pieces, full program analysis. We showed you bits and pieces today of what Nuvem can do, from a pro forma to pulling together leakage or e-scribe or everything in between. And then the third one would be determine which option of management is right for you. We went through the multitude of options. I think from this conversation, you see the complexity of not only pharmacy, but the entire complexity of the program. And so I'll leave you with this. There is a sense of urgency out there. A pharmacy takes roughly 6 months to open. There's a ton of manufacturer restrictions out there today, and they're only going to get tighter. And then I would say, lastly, talk to Burrows and any other one out there that can help you with grants. There are some exceptions that recent clients were able to get. If you remember back to the ARPA, H8F funds that were associated with COVID, they have been able to get some exceptions out there to cover the cost of opening a pharmacy. And so if you have any questions here, please reach out. My information is here. Jackie's information is here, and we'll be able to navigate this for you. Burrows, thanks for having us. Can we open it up to questions now?
Absolutely. Thank you, Chris and Jackie. That was an awesome presentation. Like I mentioned, this is kind of a follow-up to our previous 340B presentation. So this will be uploaded on our YouTube. So feel free to go back and refer to either of those presentations, and we'll also send out the slides following. But we did have a few questions come in through the chat. And again, keep putting them in the chat if you have any, but I'll go ahead and start. One that was submitted is, will we follow suit of Connecticut signing the Public Act 23-171 prohibiting contract provisions between entities and PBMs effective January 1st, 2024?
Hannah, that is a great question. We're in almost all 50 states today. I don't know every state regulation off the top of my head. I apologize for this. However, I have a big, beautiful team. If you could send me this question, I will get an answer in the next 1 to 2 days, and I will give it back to Burrows. We'll get finished up with that.
Awesome. This is one that was submitted previously, so I can just connect you directly with the person who asked that. I figured that'd be the case. But
Fantastic.
second question is, do you think rural emergency hospitals will eventually be eligible for 340B?
I think there's a lot of uncertainty in the 340B program. And so I would say, as we get through the manufacturer restrictions and Congress gets involved, I can't predict the outcomes of what it would look like. But I know that there's more scrutiny and more visibility right now in the 340B program than ever. And things always change and have been for, since 2010. And so I don't know what the future holds, but I would say get with as many advocacy groups or consultants, things like that. And let's go out to Congress and see what we can change.
Awesome. And then the third question was, how do we increase patient utilization of pharmacies in our network without risking compliance? They also said we have a contract pharmacy connected to our clinic, yet a larger part of our patient population continues to visit pharmacies they're comfortable with that are not in our network.
So interesting. This is a great example. You have a contract pharmacy on site. So you have an on-site pharmacy, and yet patients still choose to go outside of your on-site pharmacy and perhaps even outside of your contract pharmacy. You already know the difficulty, right, of getting patients to a pharmacy on site. It's very difficult. And so I think there's a lot there on education of patients, marketing of patients. If you choose a vendor like us, we'll put together marketing, we'll put together training with your current staff, medical staff, front desk staff, all of the staff, right, to talk to patients. Little things like flyers and marketing work, but even the way you change things, hey, instead of saying, hey, where would you like this script being sent? Just rephrase that. Would you like this send this script to our in-house pharmacy and pick it up on your way out? Just that little change of messaging can really go a long way when it comes to patients. And then lastly, I would say, if in-house pharmacy doesn't negate your contract pharmacy, doesn't replace them, you need to have both, because patients are going to have choice, and they're going to choose to continue to go to Walmart because of convenience for groceries and fishing supplies and their clothing, and pick up their prescription. So you got to think a little bit about how to get the patient in and how to get your whole 340B universe. So if it's not at your in-house, make sure it's at your contract pharmacy and you get the referral and all those things. So the whole program together.
And never underestimate, in the clinics that I ran, we put signs up and just said, did you know that such and such FQHC has a partnership with Walmart and CVS and JR Pharmacy? And so just even that sign, so your staff remembers too, that's great. Again, that is fully compliant. You don't have to get into the details about the partnership, but those are who we work with. And then also just making sure people understand, and also challenging your in-house pharmacy. Some of them will do home deliveries, or they'll have special little things that they can do, like at the FQHC that I go to as a patient, you can also drop off medications you want to get rid of. So that's incentive, where there's another program right there. I can drop off the drugs I don't need and pick up the drugs I do need. So again, just that messaging. And also, it's not just messaging to your providers, but also making sure your MAs know. So that way, when they're doing those refills, that they're automatically offering, hey, you can come right here and pick that up. But in a lot of rural areas, and especially in my hometown of 1,000 people, that has been a game changer, is the ability to have an in-house pharmacy and an FQHC. And I will tell you, my grandparents thought it was like the greatest thing since sliced bread, because they had a pharmacy and a dentist in their hometown of 1,000 people. And they had never had that their whole life, up until the last couple of years. So I just want to remind people, the more you're providing those services and just keeping people engaged with that, the better off you are. Those personal relationships are huge.
Definitely. Are there any other questions? If you guys want to put that in the chat, again, thank you, Elizabeth, Chris, and Jackie for those answers. Those are great answers. And I'll be sending the FAQ out as well, but I want to make sure we're not missing any other questions. Feel free to put it in the chat or unmute yourself. Or Jackie or Chris, if you have anything you want to add onto the great webinar you gave as well, if anything we missed.
No, I would say thank you for having us. If there are any questions, please reach out to the Burrows team or directly. You have our contact information. This is a process that we can provide a lot of value to. And I think it's definitely worth exploration.
Absolutely would agree. It doesn't appear that we have any more questions, so I'll go ahead and end the meeting for today. But again, we'll be sending out this webinar, and thank you again, Chris and Jackie, for your attendance. We loved having you. So have a great day.